Okay, the broadcast has been started.
All right. Okay, so I'm going to go first. Whitney. Can you all see? Can you all see my screen?
Yes.
Yes.
And I'm ready. So my project is implementing effective HPV screening and vaccination uptake at a Kentucky Health Center. I'm Whitney Graves, and my site is Planned Parenthood. This is my aim statement, as you all can read it. And my main objective is just we need to improve our screening and make sure that we're increasing our vaccination rates to 80% for our males and females. The problem, HPV is the most common STI in the United States, currently affecting nearly 79 million people, and about 14 million will become newly infected each year. HPV is responsible for increasing rates of genital wart infection and causing several cancers, including cervical, vulvar, vaginal, anal, penile, and oropharynx cancers. The financial burden of preventing and treating HPV-associated diseases estimates to $8 billion, including costs for routine screening and follow-up, cancer treatment, genital warts, and respiratory complications. Reason for the Kentucky's HPV vaccination rate is 34.7% for females and 19% for males. The Healthy People 2020 set a goal to increase the percentage of vaccination for eligible individuals to 80%. During my chart review, my chart audit, 20 patient charts were reviewed and showed that 3 patients out of 20, which is 50%, were offered the HPV vaccine, and 0 out of the 20 received the vaccination, despite being eligible for the vaccine. 6 out of the 20 people, which is 30%, received educational information on HPV and the vaccine. So as you can tell, our population at our center falls well below the national and state averages. The team survey showed results that we need to do improvement in the areas of communication and education, and my patient survey results showed that we need to do a better job at handing out information and making sure that our patients are properly informed. Outcomes. This project will help our organization follow best practice guidelines and provide high quality care to the patient. This project will help our patients receive the best care possible, which is what we always want to do, make sure we're giving them the best care, and protect them from HPV and the HPV-associated diseases. Also, increasing the vaccination at our clinic will also improve our profit. Each dose is $240. So if they qualify for the 2 dose, that means that would be an extra $480 for us. And if they complete the 3 doses, that's $720 per patient. This is just a sample of my measures that I have set up. The key stakeholders of our course, number 1, my patients, my team members, Stephanie Fletcher, Rachel Simpson, my office manager, Rachel, and our regional health center manager, Laura Miller. My initial changes are I'm going to do a weekly QI team huddle. Our shared decision aid would be a modified version of the HealthWise HPV should I get the vaccination. My process change number 1 will be the HPV screening checklist, which is a modified CDC HPV decision tree. And process change number 2 is my HPV right care bundle case management log. Barriers that I see for each ramp, for the A ramp, I see that we'll have the barrier will be lack of time and decrease in team participation. Barrier 2, barrier for my ramp B will be lack of patient time and willingness to complete. It can make the patient irritable. For C, we're not accustomed to discussing with patients and offering the vaccine, so that could be a potential problem, and lack of time for education. And for D, lack of time for administration and more paperwork to obviously fill out. And these are my references.
Great job.
Thank you.
Way to go.
Okay. Let me see.
Okay.
All right, and no one's gotten an email from Jessica, right?
No. Can you guys see my presentation?
Yes.
Okay, we can go ahead and start. My project is increasing effective care of HIV, HBV, and HCV in syringe exchange program participants in a health department. Wendy Blair Harrod, Frontier Nursing University, and my site is Franklin County, Kentucky's Public Health Department. My aim statement is increasing screening and right care of HIV, HBV, and HCV in syringe exchange program participants in a local health department by 30% within 90 days. The problem to be addressed, 1 in 10 HIV diagnoses are people who inject drugs. HCV infections have increased 3.5-fold from 2010 to 2016. There are currently 4.4 million people living with preventable hepatitis that increases the risk for developing liver cancer. And the healthcare costs are exponential for both HBV and HCV, with the highest cost being $360 billion annually. The reason for the effort is that 50% of my harm reduction team members surveyed rated their monthly meetings as very effective at promoting organization. However, 100% of team members listed lack of organization as a barrier. SEP participants revealed that only 40% strongly agree they feel confident the SEP program provides them with the information needed to make a healthy choice for themselves, yet there is currently 0% shared decision making. A chart audit of 20 charts showed testing rates from July to September of 2018 at virtually zero. You all can see the multiple zeros there. And the audit also reported that 30% of self-identified HCV positive participants got no documented right care. My expected outcomes and my vision. My short-term goal for the project is to increase the percentage of SEP participants tested for HIV, hepatitis B, and hepatitis C and linked to right care. The long-term goal is project sustainability and permanent implementation to increase standardization of care and evidence-based practices in syringe exchange programs. And I would love for my project to be a model for SEP screening and right care. This is my measures. My outcomes are to, in a nutshell, increase the screening rate and right care. My stakeholders are my harm reduction team, as you can see there, all those people, and obviously my syringe exchange program participants. My initial changes are weekly QI meetings, my interactive bulletin board with instructional flyer, one-page registration and documentation form, and a case management log. My barriers for A through D are staff shortages, lack of buy-in, stigma and bias regarding SCPs, and time constraints. For the participants, time constraints and fear of results. For C, long registration documentation process. And then for D, my case management log, lack of documentation and data. Here are my references, and thank you very much.
Way to go.
That was good.
Let me see if I can get back. Okay.
I think I'm up, right? Okay, can everyone see my presentation?
Yes.
Yes.
Okay, go ahead and start now. My name is Shani Slies. I am a nurse midwife, and I'm doing my project at Providence Regional Medical Center in Everett, which is in Washington State. My goal is to promote physiologic labor by using home care strategies for term patients in latent labor or with premature rupture of the membranes, referred to as PROM, with the goal of decreasing the admission rate from 91% of our patients being admitted prior to active labor to 75% within 90 days. The problem to be addressed is that promotion of physiologic early labor can help reduce adverse perinatal events and increase patient satisfaction. Improper management and increased interventions can increase things such as postpartum hemorrhage. Labor augmentation has also been shown to increase the length of stay. One study stated by an average of about 7.5 hours, which increases the healthcare costs and also increases the risk of adverse perinatal outcomes. A chart review performed at our site reviewed that 91% of the patients did not meet the accepted criterion of 6 centimeters dilated at admission. And then 35% of these patients ultimately ended up receiving some form of labor augmentation, even though they came in spontaneous labor. And our average length of stay for patients admitted in spontaneous labor was 40 hours. Reason for the effort, 80% of our team surveyed said that our facility should decrease the interventions that we perform in latent labor, and 88% agreed that patients should be a critical component of the team. The patients want to take an active role in their health care here at our facility, and only 48% though said that they received any sort of handouts or information on their options. And currently we have no checklist or safety forms for sending our outpatient proms or latent laborers or therapeutic rest patients home, and we have no way to adequately follow up with them or no tracking tool in place to ensure that they're getting the right care and that they're coming back when they need to. The outcome is basically our goal is that we are going to empower the patients with patient-centered care. We're going to give them safe, evidence-based options that support the normalcy of labor and birth. And we're going to do this by using a standardized process, using a tool for shared decision-making, and a tracking tool to ensure appropriate follow-up. This is my measures. I sort of restructured it, showing the different tools that we're going to use and what our goals are for the outcomes. A lot of our baseline data, unfortunately, is 0%. A lot of these things are brand new toolkits that I've created that we haven't currently been using. There were a few places in here where we had in certain charts like verbiage for like a shared decision making, but no formal tool. This is the list of our key stakeholders. I'm primarily working on this project with the perinatal clinical nurse specialist, but we also have this team here of medical directors that's involved as well. Initial changes, we're going to do triage huddles 2 to 3 times per week, a shared decision-making tool, a checklist, and the tracking tool. Concerns that we have are if the reading level is appropriate level and non-English speaking patients. Barriers are primarily time, skepticism about the new tools and the research behind them, psychological safety, meaning patients often don't want to disagree with their providers, and then compatibility with the EMR, and also just forgetting to fill out the tool. These are my references for this presentation. All right, and done.
Great, that was awesome.
Good job.
Good job. Figure out how to unscreen share here. Okay.
Can you guys see my screen?
Yes.
Okay. I'm going to go ahead and start now. My name is Tia Brutcher. My QI project is focusing on timely protocol activation for adults with chest pain in Bowen Memorial Hospital's emergency department. The aim statement. The aim of my QI project is to reduce door to departure time for patients presenting with the chief complaint of chest pain at Bowen Memorial's emergency department by 20% within 90 days. The problem to be addressed. A look at the problem. Every 40 seconds, someone in the United States has a heart attack. For ERs around the nation, chest pain is the second most prevalent complaint, accounting for greater than 8 million visits per year, with a cost of $10 to $13 billion per year. Ultimately, of these patients, less than 10% are actually diagnosed with acute coronary syndrome. The reason for the effort. Bowen Memorial's triage process lacks standardization and efficiency. Patients lack engagement and understanding and primarily measure their satisfaction on wait times and length of stay. This has to start from the onset of their care. Goals for this project include an increase in patient and team engagement and satisfaction, establishing outlined expectations and standard of care that lead to an increase in efficiency, leading to reduced length of stay and wait times. And we're going to leave the facility with deliverables for later alteration for other chief complaints. This is my measures worksheet. The aim is to reduce the length of stay from arrival to departure time by 20%. Ramp B is the patient shared decision aid to be used with patients with a heart score of 0 to 3. It will then be surveyed to gauge the effectiveness. Ramp C is a triage checklist to be used for each patient presenting for care in the emergency department. And the outcome is if they have chest pain, the triage protocol should be started. Ramp D is a case management log. All patients that are seen for chest pain should be logged, and will then gauge a percentage of right care that's delivered. And then the balancing measure is to continue to strive for high levels of heart score documentation. My key stakeholders are an interprofessional multidisciplinary team with patient and family focus. Initial changes, RN education and twice daily huddles, personal utilization of the shared decision aid, electronic reminder utilization and visual prompts for checklist utilization, and then a weekly chart audit. Barriers for A through D. The barriers vary according to the ramp. I'm going to work to address with continuous quality improvement and evidence-based interventions. These are my references. Thank you.
Perfect.
Okay, can you see my presentation?
Yes.
Okay, my presentation is regarding, I'm Nicole Wilson, regarding providing effective care to patients aged 7 to 12 using recommended guidelines in a rural clinic. The AIM statement is to increase well child exams and recommended immunizations to 50% in patients aged 7 to 12 by March 31st. We chose this age group because our gap showed they are the ones that are perceived as healthy and don't normally come in for well child exams and immunizations. The immunizations, of course, are essential for disease prevention. The most potent one here would be HPV, with an estimated 14 million new infections yearly that results in 1.7 billion in direct medical cost. And it's also responsible for 70% of cervical cancer worldwide. Our clinic has had a 17-year-old patient with stage 4 cervical cancer that required chemo and a hysterectomy. So it's real and it's everywhere. Reason for the effort, the national target immunization rate is 80%, and our current clinic immunization rate for those 3 vaccines is 24.3%, which is well below the national average. We fail to identify patients when they come in, especially those that come in a lot for sick visits, and you don't think about scheduling them for a routine wellness exam. So the expected outcomes, my 10,000-foot view is I would love to increase the clinic vaccination rate to the national goal of 80%. Of course, we want to have some standardized tools to guide the staff and engage the patients in their self-care. My measures, my aim is to, within a 90-day period, there will be a 21% increase in annual well child exams and recommended vaccine rates with the use of effective care at Lifespan Health Medical Clinic for patients aged 7 to 12. One of the balancing measures I used was we don't want appointments to run over 45 minutes, as that would increase the patient dissatisfaction score. We're going to use weekly QI meetings, patient engagement tool, a pre-visit screening checklist, and then a case management log. Key stakeholders, of course, CMO, CEO, the board of directors chair, and the quality improvement department, as well as patients and other providers and staff at Lifespan. My initial changes will be weekly QI meetings, patient engagement tool, a pre-visit screening checklist, and then the case management log. Barriers, of course, time is always a problem. Having available appointments, because well child exams do take a little longer. Patients, I have found, are not always knowledgeable about needing an annual wellness exam or what vaccines they need. It takes time to pre-screen, and all of our clinics are not set up to have the vaccines for children. So, and then one of the other barriers would be failure to log. And as we all know, patients do not always have up-to-date contact information. And these are my references.
Very good.
Good job.
Okay, so I guess I'll start with the discussion questions. I guess I chose who told a compelling story to them, and what was it about their story that compelled me specifically. I chose two. The first one was Tia. When you made the statement about the 40 seconds, every 40 seconds someone comes in with a heart attack, and then you said only 10% actually have acute coronary syndrome. I felt like that was really huge, because when you think about like wait times in the ER and like costs and stuff, I always think about like people who come in with chest pain and things like that. And also I chose Nicole. I think what was really compelling about yours was when you told about the 17-year-old patient who had stage 4 cervical cancer. I feel like that's just ridiculous to even think about. And having a hysterectomy at 17. That's crazy.
I agree. That was my compelling story, was the 17-year-old. My mouth dropped open.
We also have a 22-year-old who just had her 3rd child, had a normal pap smear after delivery, and hers is now stage 3 cervical cancer due to high-risk HPV.
Oh,
Wow. That's terrible.
So Whitney and Nicole, you guys are both going to do great things for HPV treatment. That's awesome.
Okay. Wendy, what question would you? I'll let you go next.
I'll just do number 2 from a graphic design standpoint. Whose PowerPoint was the most appealing and why? Tia, I really liked yours because it had the it included the FNU logo. I always think that makes for a great presentation. I've used that in the past on my presentations, and I wish I had, after seeing yours, I wish that I had done that again on mine, but time was of the essence. But it looked great. I really liked that.
Thank you.
And I also liked Whitney's. The colors that you used were visually appealing, and it flowed real well.
I agree. I thought that one was good too. Actually, they were all good except for mine, which was just plain and white. I put one picture on there.
I liked your picture.
No pictures. I went minimalistic.
Well, I remember before she said, "Don't spend a lot of time." So, all right, fine. It'll be white this time, I guess. But then I have jealousy because all yours looks, very nice, and you had some nice pictures as well, Nicole. So.
Okay, Shannon.
Okay, let's start the questions. All right. All right. I'm going to go with what was the most difficult aspect of this term, just because that seems like a good opportunity for me, something I have an opinion on. The most difficult aspect for me, and I'm also going to tie this into my other question that I'll answer, is what would I give for recommendation, is trying to figure out how to make my project work, which has been really challenging because for my particular project, I have not been able to nail down like hard financial data, for example, incidence of disease. There's things that are similar to it, but not quite the same thing. So part of the hardest part for me is not having sort of like a vetted tool, vetted project. Like, for example, postpartum depression screening, and we use this tool, and it's very evidence-based, and a lot of places do it. And that makes the project a lot easier to figure out. So I feel like it's been challenging and sort of losing my way trying to create something essentially from sort of scratch that's not already vetted and out there. And if I could go back in time, I would probably do a project that was a little more simple and already vetted for my DMP project. And you can always, learn the process on that and then in the future, apply that to other quality improvement projects that you're doing. And that's been really, really challenging, not being able to find the sort of data that that they're wanting, and having those shocking statistics like some of you guys do with, every so often this person has a heart attack and this is how much it costs and this and this. And it's really hard to kind of find that sort of data for my project. So
I can definitely understand how that would be challenging. That was one of my things. I was like, I don't know. There was like other topics I wanted to do, but I couldn't find certain data. And I was just like, I don't have time for this.
Yeah, I know. Now it's too late for me. So I'm just going to have to make it work and tweak things. But I think definitely looking into that and reviewing projects ahead of time is a good idea before you start this course, and having a good idea of what exactly you're going to be doing. So.
I had initially planned on working on diabetes, and then the analysis at our clinic of what they needed me to work on turned out to be well-child exams and immunizations in those age 7 to 12. So that was not my first choice of topic either. Yeah,
I wonder how many people have that issue where the facility thinks, okay, we have a real problem with this, but then when you're doing the chart audits, you're like, okay, well, we can maybe improve, but it's still much better than the national average. So it's a little harder to make a case. I wish we could hear Jessica's presentation, because hers are just shocking. Remember, she was saying at her facility, they have a 15% choreo rate. And I still remember that, like, weeks later, right? Because the average is about 1. I'm like, wow, what is going on? And like, what has she found out? Because I want to know so that we don't have that issue. Anyway, so I just thought it was like, those things stick with you, and I'm having a harder time finding those sorts of things. So.
Tia, you want to go next?
Yeah, I chose from a graphic design standpoint, the PowerPoint that was most appealing, and why. I like Whitney, I like yours with the colors. And then the monetary gain from actually administering the vaccines, I thought that was pretty staggering. Like, you had it all calculated out. I thought that was cool. Like, you could see that when you implemented it easily, there's something even just financially to gain. So I thought that was cool. And then Nicole, I like the shading behind your measures worksheet on your slides. I like the photo. And then obviously that personal story about that 17-year-old is just like heartbreaking and eye-opening. And I can definitely see from the way that you presented the information how your proposed changes could make a huge impact in your facility.
I see a lot, unfortunately, a lot of STIs in the young population in my county. The earliest, I had a 14-year-old a couple of years ago I diagnosed with herpes. And it's just, it's in the young population because, the standard of care is we don't even start pap smears until 21. So had we have done that, that 17-year-old probably would have never made it to the age of 21. The gynecologist that works with our clinic, or works for our clinic, he says you start within 3 years of them becoming sexually active, if not sooner, because of that patient that we had.
I gotta agree with you on that, because like at work with Planned Parenthood, we always have those young girls coming in. Like I have one patient, she just turned 17, like maybe last month. And I've seen her 3 times and she's tested positive 3 times for an STD. And I mean, they're like kind of laughing about it. It was her and her friend, and she's like, oh my gosh, I have this again. And I go, it's not funny. There's nothing cute about this. Take you some lots of condoms. We need to have one-on-one sessions. It's crazy.
The one that I diagnosed at 14 with herpes, of course, she has GC chlamydia almost every time she comes in. And I've asked her about it, and she's like, I don't like using condoms. And I was like, do you realize that eventually this is going to be where we can't even treat this?
I always say that too. And you were talking about my numbers. One of the main reasons I put up those numbers, we had a meeting maybe a couple months ago. We have a new biller, and he was showing how within the last year we had lost like $1.something million in revenue. And so he's been really teaching us like how to, how to redo our charting and make sure, because, a lot of times we don't learn how to do charting correctly. Not charting, but coding. I'm sorry, coding. So we did a whole coding. It was all day on coding. And so I'm just trying to find more ways to like get more money for, you know, for us, especially, they're always talking about defunding Planned Parenthood. So I'm like, we need to figure
When
out.
you really drew that picture, you could see that, like, I mean, it wouldn't take any effort, and you could really have a, you know, pretty good financial gain from what you're doing.
Exactly. So thank you for noticing. Nicole?
Okay, so I'm going to look at number 5, health disparities in, I don't know that it was necessarily included in the operational definition, but Wendy, the syringe exchange program. So did you look at the patients that were coming in? Did they have insurance? Did they not have insurance? I'm assuming the majority of them probably don't.
I did, and most of them do have insurance, but it's Medicaid, it's government funded insurance. That the program that we have is not really funded by insurance at all. It's through taxpayers' dollars, and then the testing is funded through the state lab offers the blood testing for hepatitis for free, and then we have they'll also do the HIV testing for free. So if the patient is going to get a blood draw, we just do all 3 blood draws and all 3 tests in a single blood draw, rather than poke their finger and use the Insti test that's provided through the Ryan White grant for HIV. So if they only want for cost purposes, if they only want the HIV test, we'll do the finger prick. And then if they want all 3, then we'll do the blood test and not the finger prick.
What kind of clinic are you at? Is it?
It's the health department.
Okay.
And my subject was kind of difficult too, back to what Shannon was saying. It's kind of a taboo thing, the syringe exchange programs. So for me, it was really interesting, and it wasn't my first choice, but I fell madly in love with it. I had to do 4 days of harm reduction training to be able to actually do the exchanges myself, because I wanted that training. I wanted to be able to do it and look at it from the worker's point of view too, because I don't work there. I'm an urgent care NP. That's just my site for my doctoral project. So it was hard finding statistics and vetted tools, and I ended up having to create most of mine from scratch, and that's been a ordeal. But I think we're there. I think we're okay. But yeah, it was a different project, and it was a whole different population and a whole different set of learning skills and communication skills, everything to deal with them.
Well, Wendy, I'm really impressed with what you did, and it's kind of cool that your project's going to be, I think, different from, you see a lot of this, essentially the same projects in different sites when you look through the ones that they have as examples. And so I think that's really, really cool. I created all my tools myself too, and I'm presenting them to the maternity care committee, and I'm a little concerned since, they're not vetted tools. I did obviously use the research to create them, but I'm just wondering how those are going to, go over with them. So
yeah, I did get one of my forms approved by the form approving bodies at the health department. Right. They had to say, okay, I could use it.
Wendy, if you don't mind me asking, why did you not do your project? How did you end up at the health department instead of the urgent care center?
I didn't have a job. I hadn't found a nurse practitioner job by the time that I had to choose. So, and I love public health. I would love to have a job in the health department. And I actually went there and told them that I was a doctoral student and I would love to work in public health. And if they didn't have any positions available, I would love to do my project there. And of course, they never have any positions available, but they said, sure, come on, you can do your project here. And I've been working with them ever since.
Oh, okay, nice.
Tia, I also had a question about yours. I remember from the last touch point we did, the statistics of the wait time in your ER for chest pain patients. That was just staggering to me. I'm in a small community and we have one ER. All the local hospitals around us have closed. The next tertiary care hospital is about 50 minutes away. And so we fly a lot of people out of here for that very reason. But that wait time for the chest pain was just staggering to me in your area.
Absolutely. And that being the primary guiding force in patient satisfaction too, because as I've repeatedly said, our facility out of 15 in the entire system, we're at the lowest level of patient satisfaction. And the reason for that is throughput. Like, the reason for that is we're not using the tools that we already have in place. They're evidence-based. We have these protocols. It's just, they're not completely unutilized, not underutilized, So that's, getting that buy-in from the nurses to like act at the highest level within their scope to get this stuff going at the onset of their care, I think is really going to make a difference. It's just getting that engagement from them. It's going to be hard, I think.
I agree. I used to work the emergency room, and we had the protocols in place. When somebody walks up to the front window with chest pain, they page code heart, and that means you go get the patient. They get an EKG with it and are seen by the physician within 15 minutes.
Yeah, that's the standard of care is arrival to EKG completion is 10 minutes, and we're completely at, our average is 42 minutes.
Oh, wow. I have a question for you too, Tia. Like in our ER, we're a level 1 trauma center, like our local hospital. And when you walk in the door, they triage you, and we have kind of like an urgent care in the ER. Like, they figure out whether you need to go to the ER or it's called first care, but it's like urgent care. Do you all have that at your hospital?
Is that staffed by a provider?
It's like staffed by at least a couple of nurse practitioners and a nurse, because I thought about working there.
Because that is, so the medical director, the primary person, my sponsor, that was his goal. That was the goal of this project, to show the need for a nurse practitioner out there in triage, which would have been easy, but I think it's completely redesigning the process that we have in place presently. So when I started looking through the patient tracer and the chart audit and all of these things, I started telling him, like, I don't necessarily think it's integrating a provider. Like, that is an evidence-based solution, but that's a costly one because you're having to hire a brand new provider to staff that area when we're not even using the things that we have in place that can increase efficiency and throughput in the department presently. Like, all of our protocols, I sat there the other day because it's been hard doing this because, as I said, those protocols are so underutilized right now. So I personally have a 4-year-old little boy. And this young little 4-year-old checked in with the chief complaint of abdominal pain the other night. I sat there and waited because they've been kind of getting on me for initiating all these protocols and testing kind of my project already and varying chief complaints. This kid sat out there for 3.5 hours without a single order put in. I sat there and thought, if this was Jasper, my son, he would have already gone to the bathroom probably 15 times. And if he got put back in a room and they came to me and asked me for like a urine specimen, and of course he can't pee once he's placed, I am mad, like real mad. And that's these chest pain people. When you present out front with the chief complaint of chest pain, we have a whole protocol with EKG, troponin, basic lab work, like all this stuff that can be started, but they wait until the provider is available. Well, oftentimes that wait is like 30 minutes. There's a complete disconnect. So I can definitely see where you're coming from and getting a provider out there. I just, from a not having to completely redesign the current process and seeing all of these gaps that we already have, like, let's start with using what we've got first.
Right.
You know what I mean?
No, I agree. When I asked them why they put that in there, they said because they were because we have a lot of wait times, because we have like a lot of gunshot wound violence, and then of course we have the older population and things like that. So they said, oh, we put that over there because just like when I went down there to shadow, a lady came in there for a yeast infection. Like, she came to the ER during the day for a yeast infection.
My husband's a firefighter. Someone called 911 once for that.
Yeah. Oh, wow.
For yeast infection. Wanted to go to the ER.
Yeah, like,
I had a 28-year-old the other day, just last night, 2 nights ago. He presented, he'd been on Bactrim for a sinus infection. for the past 8 days, and he started hiccuping at 3:15 in the morning and thought that that was an allergic reaction and was convinced. And I had to spend 15 minutes telling him, that's not a thing.
Yeah. Like, I just couldn't believe that someone came to the ER. Like, it was like 3 o'clock in the afternoon, and they came to the ER for a yeast infection. I was like,
Oh, yeah, girl. Yeah.
go to like little clinic or
No, you got to pay for that, girl.
yeah. I'm just like, oh, okay. Like, I wouldn't even imagine to come through. Like, I don't know. That's a whole different conversation.
Yeah.
Before we had some of the protocols in the place in the emergency room, we used to have a lady that would call the ambulance and complain of chest pain. And then when she got to the emergency room, we would do the EKG and she would say, okay, I just needed a ride to town to go pay my electric bill.
That's really common. That happens a lot up here too. People use 911 for that, to get a ride from the outlying areas into the city.
Wait, Shannon, where are you from again?
Washington State.
Washington State. And then where are you from, Nicole?
West Tennessee.
And then everybody else, where's everyone else from?
Oh, I'm from Kentucky.
Kentucky.
I'm in Muncie, Indiana.
Okay, I've been there. All right. Good conversation.
Yeah.
Does anyone have any other questions?
I was going to say, is all the questions, what about what gives you the most angst about the next term? Who wants to take a stab at
Oh, I will. I'm afraid this kind of where I don't know if y'all have all felt this way. I think you probably have. There's not a lot of guidance before projects are due.
Sorry, Dr. Butler.
Yes, Dr. Butler, you're great. I love you. But it's a little frustrating, and I don't know. Sometimes I feel like I'm spinning my wheels, but then when I get something back and she's like, great, you're on track. I'm like, okay, good. But I worry sometimes about the implementation, but it'll be okay.
I'm worried about the measures. I just don't feel like I'm getting them quite right. And then I was reading on one of the Facebook groups about the implementation process, and someone was saying, make sure you have your measures just as you want them, and you know what you're measuring, you know what you're doing. Otherwise, implementation is going to be really hard. It's like, oh, I still feel so confused by those. So I'm going to have to just keep looking at it, I think, and playing with it. But it's been very, very challenging for me. I feel like it's in another language.
Me too. I agree. I think, and I was always very, and I know that Dr. Butler has been a saint with being patient with me, but it's just so frustrating because I know what I need to do to help this problem and to try to fix this, but I can't use the language that is necessary.
Yeah, that. Yeah. Mm-hmm.
I mean, and I felt like I'm like, I know I'm not
stupid.
Not intelligent. I don't want to use the word stupid, but that's how I felt. I'm like, I just don't understand. I know what I need to do, but I just don't understand how to tell you how I need to do it.
Yeah. That's the way I felt. And like I said, by lack of direction, I think what I kind of more meant is we are doctoral students and we're supposed to figure this out because when we get ready to do another quality improvement project, we're not going to have an instructor there to tell us this is what you do. Mm-hmm. So that's what I've kind of struggled with too, is exactly how to put into words what my plan is and what I want to do.
Well, and I think even now that you have the plan, it's like next term seems like a completely gray area to me. Yeah. Like, I do not know. I feel like day one, I'm just glad to get done with this.
It's that IHI jargon, I think, has been the most challenging. Like, I understand the ideas behind it, but then it's like just the terminology is all different, like operational definition and process measures and outcome measures. Like when you break it down, it's like, okay, well, that makes sense. But then when you add all these different words for it, something about that just throws me off.
Mm-hmm. Yeah, I don't know what it is about the measures. And like me and her had a meeting last night, and I'm just like, I feel like I'm intelligent. I told the girl last night at dinner, I was like, I mean, you don't think I'm smart, right? I'm really and like she asked me a question and she's like, and she asked it and I was like, I mean, I don't know and I told her, I was like, look, I don't even know what you mean. Like, can you I was like, she probably thinks, oh my God, she gets on my last nerve. And I'm just like, I don't know.
Yeah. Even the feedback, and love you, Dr. Butler. You're so patient. I know she's going to be watching this. But the feedback, like I'll read it and I want to incorporate it, but sometimes I don't even understand what she means. I'm looking at it. I'm like, well, wait, what? I printed it all out, all of her comments. I'm going through with the check mark. I'm like, well, wait, I don't know what that means though. Hold on. I'm like, oh,
you're like me. That's exactly what I did. I printed my comments and then I even here.
Yeah, I printed through each one after I go through. Okay, she said to do this, check, and then I'm like, well, what does that mean? Now I'm confused again.
Yeah, that's how
she's trying to help me, but
I was like, you wrote me this comment. What does that mean? What did you say?
I went through the thesaurus to try to find synonyms to the words that maybe I could understand better.
It's not there. I already tried that. And someone told me that I have a friend who finished a couple terms before me, and she was just like, planning is awful. And she's like, and I think FNU made up all those terms because I would Google them and I couldn't find them. I'm like, I think IHI actually made them up. I figured this out. This is all IHI jargon. And I'll go through and I'll read like, okay, this is what an operational definition is. This is what a process measure is versus an outcome. And this is how we, make it into a numerator denominator. And I'll look at all that and I'll have it down. And then a few days later, I'm like, well, wait a minute, what was that again? So I've got to really get these measures, I think, straight in my head. Before.
Yeah, when I say papers galore, my nephew came over. He's like, "Why does your desk look like this?" I said, "I don't know. I don't even know where to start. I don't know."
Yeah.
I even moved another smaller table into my office because I needed more desk space to spread stuff out.
Oh, let me fall on the floor of my whole office. I have piles in the floor.
That's funny. I have that too.
I love it. Just grind.
Yeah. Binder. So, do we have any? Do we have any advice for any incoming 740 students?
No.
I answered that one earlier, but I said really trying to pick a project with vetted tools, I think, is an easier way to go for your first initial project when you're trying to learn this jargon. And I don't want to use the word jargon, but I can't think of another word, right? Like I know. Yeah. So I think doing a project that already had, like, you can find a gap where it's like, this is supposed to be done. We already know this is supposed to be done. We have so much data showing this is supposed to be done. Here is a vetted tool that already exists. I think that makes it probably much easier when you're in learning mode. I don't know, Wendy, if that's been your experience, but I think,
I feel like, and I know that they told us at the beginning of the term that you don't have to be passionate about your subject. I'm telling you right now, if I had not fell in love with this and I didn't love public health and I wasn't always one of the go for the underdog people, I could not have spent as much time and effort as I have with this on something that I couldn't give a hill of beans care about. I just couldn't have done it. So I feel like people need to find something that they feel strongly about and just find a place that will let you do that.
Mm-hmm.
Well, I think it's important to not have a definitive plan up front. I think it's important to have the resources that are evidence-based that you can do the shared decision aids and stuff with, but to not have it set in your mind what it is that you're going to do. Because oftentimes, when you're in that before the term starts kind of phase, you're thinking about what this project could be and what your ideas are, and to not get hung up on that because it's going to completely change.
Yeah, I think, and I realize that no one wants to give up their vacation, but looking back on it, I really wish it doesn't take that long to just audit 10 charts, right? I wish I had done a chart audit prior to the term, because a lot of the things that my facility thought were problems, well, I'm not really finding a problem here. This is an issue. That's great and all, and then getting to a point where it's like, I have to find a problem, because if I don't, it's getting too late now. I can't just completely switch tracks. So I think knowing that you have a viable project that shows a clear gap before you start the term would have been really beneficial to me, because it became a time issue. So
I agree. I feel like if we would have done the chart audit first, then I'd be like, oh, okay, it would be an easier flow versus or doing the patient patient tracer, then the chart audit. I think need to be like the first 2 assignments. Because then you're like, everything flows, I think, after that. Mm-hmm. To a certain point, things flow. Well, at least they flew for me. I don't know.
Right.
Yeah.
Yeah.
And doing the chart, BBB, that would have been helpful before the charter was due. Yeah.
More examples. That's what I wrote in my eval. I need to see like examples, I guess.
That's me. If I can see an example, then I can be like a good quality example of what you want, then I can I'm like, oh, okay, I know what you mean.
Yeah, a lot of apply it to your topic. Yeah.
The time, I spent countless hours just trying to figure out what was required. Like, what is it exactly that I'm supposed to do? Like, doing it wasn't that big.
Exactly.
It's just like a labyrinth of trying to figure out what am I supposed to do here.
Well, I'm glad I'm not the only one.
And according to the Facebook page, this is pretty, consensus throughout.
Yeah.
The Facebook page has been a big help too.
Oh, yeah.
Oh, yeah.
Sure. Yeah.
Which one are you guys all on? Because I'm on just the basic Frontier DMP, but I think there's a more specific one. Of course, now we're already through planning, so
it's more planning, I think.
So
there's probably another one for implementation, a whole new.
One of the students actually just started it.
Oh, where's it? Y'all add me?
Me too.
It's called DNP PC 740 Planning Fall Term.
Okay. Well, again, now we're almost done. So.
Well, I'm hoping she'll just change the name to Implementation Spring Term. So.
Oh, okay. Yeah. All right. Well, I think we kind of everyone answered questions, right?
I think we all did well.
We missed one, and it's what prep did you do that helped you stay on time, not to read your presentation, and engage the audience? I think that's the only one we missed.
I struggled with that. Mine was a little wordy.
I struggle with that because I fly through it, and that's just my anxiety, and I know that.
I think it was who was it? The HPV. Yeah, that one was good because it was very succinct, and I'm like, oh, that's what she means. Because when she said one of the things I had the hardest time with was the rationale. When she said, okay, I want national data and numbers and this and that on, each of your 4 core interventions. Oh, and 4 to 5 sentences, please. I'm like, what? Like, how can I have national? There's four interventions. I felt so stupid. You want national data and local data for each 4 sentences. I don't understand. I'm so stupid that I don't even want to ask that question. Right? That was kind of my response to that, and I added some semicolons. So that I was really struggling with that. But I like the way that you did yours with that presentation, and it was you did a nice job of keeping it very clear and simple. And
I try to put, like, for how I prep, I just try, because I know, I feel like in my master's, they say you don't need more than like 7 words in a, a sentence. So I was like, okay, I'm just going to do the minimal. And then I wrote notes. And then I was like, I'll just read my notes.
Yeah, the charter thing is the one I'm struggling with, where they want you to like write it out, because it goes against sort of what I've been taught as a writer, which is shorter, clear sentences. Well, I can't get it done in 4 short sentences. So
I feel the same way because I have stats on 3 different diseases.
Yeah.
Yeah.
That's a whole different ballgame. I mean,
That was me, and mine is focused on all 3 immunizations that are recommended for teenagers for that 7 to 12. But of course, HPV is the one that keeps coming to the forefront because it's the one with the most staggering statistics. Pertussis has been in the forefront, but it's better. And then Menactra, we've done so well at doing that. B is about the only serotype you're going to have an infection with these days. So the HPV just keeps coming to the forefront when the intention was to do all the immunizations. Of course, that's the one that's not required for school. It's only recommended. So that's the one with the lowest numbers.
Do you think that's also because of the stigma behind like sex and all of that?
I do. And what I try to do when I talk to the parents, and I always talk to the students too, I tell them, I'm going to talk to you just as I did with my daughter. This is not a get out of jail free card. This is, even if you wait until you're married to have sex, that doesn't mean your partner did. And if we could prevent cervical cancer, why would you not take the vaccine? I will be 46 next week, and I just started the HPV vaccine series. I'll have to pay for the second, for the following doses. But since they increased the age to 45 and I'm still 45, I don't plan on, my husband, anything can happen to him. And what if I do remarry? Those things. And when I tell them that I've gotten it myself and that I got it for my daughter, sometimes that helps. But a lot of them, there's still that stigma out there. They saw a YouTube video of somebody having a seizure and it was from the HPV vaccine. So they don't want to do that.
Hiccups from Bactrim, girl. I done already told you.
Yeah.
And they're like, oh, I saw this one video where they said the HPV vaccine caused this girl to have paralysis or they're blind. And I'm like, oh, I haven't heard that. But,
Yeah. Good for you, though. Yeah, I was excited when they extended it. I remember being in my early 20s when it came, and they were still like, oh, if you're not a virgin, then you can't have it. I'm like, that doesn't make any sense. Even I know that doesn't make any sense. And I wasn't even a nurse yet at that point, right? I was like 20 years old, right? Like that. And I was just so angry about it. I'm like, just, you can have had sex and, maybe not contract, it just infuriated me even at the time. And then now, of course, they've changed all that. And I'm like, well, I've been married for 12 years. I think I should get it, like you never know what life's going to be. Nice if it was covered by insurance.
Funny story about the vaccine. They were doing trials here in Louisville, Kentucky, and I was in the group, like I was one of their test subjects. I was broke college student, needed money. And so I was a test subject for the HPV vaccine. So my mom's like, why did you do that? I'm like, girl, it's broke. It's hard times. But now I'm protected. So then they sent me a letter after it was over. I was like, you were part of the intervention group. And I was like,
that's pretty cool. All right.
Well, questions, comments, concerns?
I think we got them all. I think we've had a great discussion. If nothing else, it was a bonding experience.
Agree.
And I agree. See all of you all at graduation in September because it's now in Lexington.
Yeah. Thank you, Wendy, for saving my bacon when I couldn't get the link to work. I appreciate it. I was getting really worried there. I'm like, oh my God, what are we going to do? Because I can't get a hold of tech support. And I'm looking through that handout they sent out. And I still don't know why. I'm going to have to look into it later because unfortunately, I don't think this thing is going to go away. So
we got it. Teamwork makes dream work. I will stop the broadcast and email everyone their links.
Okay. Thank you so much. Y'all have a good Saturday.
Thank you.
You too.
Thank
Bye.
You. Bye, guys. Bye.